Hello, good evening, everyone. Welcome to another session of First Aid AMC Random MCQ discussion. So this is going to be the first part for the month of July. So how are you all? Are you all doing all right? So before we start, can you please let me know whether you can hear me as well as whether you can see the screen? Okay, thank you very much for that. Thank you. Yes, everything's okay now. All right. So let's start with today's set of questions. Like we did in the previous classes, we'll be discussing some random MCQs today as well. Okay, so this is the first question for today. 65-year-old with regurgitation for 5 years responded to PPI, that means proton pump inhibitor, 40 milligram. On pH assessment in esophagus, pH less than 4 for the 10% of time in the 24 hours. What is the management? A, increase PPI. B, fundoplication. C, elevate the head end. So we'll be continuing with the rest of the June questions in this one, in this session as well. So what do you think here? Should you increase PPI? Should you go for a fundoplication or elevate the head end? Okay, let's see. What do you think? I'll give few more seconds for you all to respond. Okay, so there seems to be a bit of confusion between the two answers, answer A and B. Some of you think we should increase the PPI, while the rest think we should go for a fundoplication. Okay, so what are we dealing with here? So let me just discuss this question. So we have a 65-year-old with regurgitation for 5 years and responded to proton pump inhibitor 40 milligram. So this is a case of GORD, or your gastroesophageal reflux disease. Now, this person has been on a PPI and he has responded well. They have done a pH assessment and pH is less than 4 for the 10% of time in 24 hours. So what is the management? For you to come to an answer here, you should know what does this mean. This pH value and the 10% of the time, what does this mean? So that is the first thing that you should know to come to an answer here. And then you should have a good understanding about the management of GORD, or gastroesophageal reflux disease as well. So let me just discuss a bit about this pH testing. Okay, so hope you can see the screen. So this is a lengthy article on gastroesophageal reflux monitoring, pH and impedance. But you don't need to know all of these for your level for the sake of the MCQs. I have just shown this article. For those of you are interested to learn more about this, you can read this. This is like a lengthy and a very descriptive article on pH monitoring and how to be done and everything and so forth and so on and so forth. Okay, what we need to see from this is there's a table. Okay, so I'll take you to the table in this article which shows the normal values for the ambulatory pH monitoring. So I think all of you know what this pH monitoring is. This esophageal pH is monitored over a period of about 24 hours, and based on that, usually the cutoff that is taken is a value of 4. A pH value of less than 4 is considered to be severely acidic and relevant to GORD. Not only the pH value, the time period in which the pH value less than 4 was noted is also very important. So just a pH value of less than 4 for 1 or 2 seconds will not be very significant. So they have this table. Don't worry too much about this. Now they have classified as proximal esophageal pH monitoring and distal esophageal pH monitoring. And this time period in which pH was less than 4 as a percentage. So they have measured that total period, upright period, recumbent period, and for GURT, for normal values. So the normal value, for example, of total period percentage in a proximal esophagus would be less than 0.9. distal would be less than 4.2. Okay, so likewise, they have classified pH monitoring and the normal values. Now, the thing is, don't worry, you don't need to remember these normal values, but note something for you to notice. You can see all of these are less than 10. Okay, so all of these are less than 10. Maximum is this one. Upright period for distal is less than 6.3. All of these are less than 10. So in our case, if you remember, that person's pH was less than 4 for about 10% of time in the 24 hours. So that is a significant value. That's not normal. That implies that this is not normal and this person has GORD or this person has acid reflux in a disease. Okay, so that being said, now that is what you need to know about pH monitoring, nothing much. Then a word about this GORD. I think you must have already learned about this in our theory classes, but just a brief overview. Now, this is a good one. This Australian prescriber management of GORD gives a nice overview. I'll be just giving you a brief overview of management. So when you consider GORD, now you know what the symptoms are. Your heartburn, that is described as a burning retrosternal rising sensation, that the people with those symptoms we consider as a GORD. Okay, now there are some things known as red flags. Okay, when you have these red flags, when you don't have these red flags in a patient coming to you, you don't need to go for any gastroscopy or any investigation. You can clinically diagnose as GORD and you can start empirical treatment. But if you have these red flags, you have to consider gastroscopy because this might mean something else other than GORD. For example, dysphagia, weight loss, this might be a carcinoma or something. And this duration, more than 5 years, epigastric mass, age more than 40. Likewise, you have a set of red flags. If it is present, you should consider gastroscopy. If not, you can clinically diagnose and go for an empirical treatment. So again, now the endoscopy, when you consider endoscopy when you think of an alternative diagnosis, not to confirm GORD. So if you think of a cancer or a Barrett esophagus or malignancy, then you will be considering endoscopy. But for GORD itself, there are indications for gastroscopy. That is when the symptoms are persistent even without responding to treatment and treatment complication, or for considering the patient for any sort of a surgery. Okay, so you can, if not, you can clinically diagnose and start treatment. Now, these variants all are not indicated. Esophageal manometry and pH studies, not usually recommended for everyone, but it is considered only for few patients who are refractory to the treatment or when you want to do a surgery for that patient. Okay, so when it comes to the treatment, lifestyle modification is the key. I hope all of you know reducing the spicy foods and elevation of the head end of the bed and avoiding meals for 2 to 3 hours before bedtime if nocturnal symptoms. Then weight loss is a very important thing. Then other cessation of tobacco and alcohol. And those things are like lifestyle modifications. Then when it comes to the pharmacotherapy, the main like gold standard therapy would be a proton pump inhibitor. Now, if you diagnose it clinically and start empirically, we usually start a proton pump inhibitor. We ask them to take usually started with a once daily dosing, 30 to 60 minutes before meal. And we usually consider it as a trial for about 4 to 6 or 4 to 8 weeks. If the patient is responding to that proton pump inhibitor, we think, okay, this is GORD, and then we can consider, once they respond fully, then we can consider reducing it to a minimal dose or reducing it to a dose when required. So not as a daily dose, but taking only when necessary. We can consider that as well. Now, if the patient is not responding to once daily dose, you can increase it to BD dose or twice daily dose if no response, if it is not a good response. Okay, now if you stop the PPI for the patients who respond, sometimes they might get symptoms again, like a relapse. But it doesn't mean that the treatment was a failure. It means that this is a chronic disease anyway. So there are adverse effects. You can leisurely read, and if the symptoms are persistent, then you can, as I told, go for twice daily doses. And even if it is still resistant, you can consider surgical treatment. So the indication for a surgical treatment would be GORD with refractory symptom despite maximal medical management or intolerant treatment, or symptomatic complications unresponding to medical therapy. Okay, so those are like the indications. You don't go for surgery at once. You are going to try with medical management. If it fails, only you're going for surgery. Now, the recommended surgery would be laparoscopic fundoplication. That is like the most common surgery that is being performed. There are a few endoscopic procedures as well, but they are limited by the durability of symptom relief and lack of correlation of pathology. So usually when you are going for a surgery, you are going for fundoplication. Okay, so that's a very brief overview of GORD management. I just wanted to touch upon it, because, not to discuss it in detail, because you will be learning it in your theory classes. I think already you must have learned. Okay, having said that, let's go back to our question. So we have a patient who had regurgitation for 5 years. Now, okay, can somebody tell me what is the important keyword in this question? Now, I always ask that question. Like, what is the important keyword for you to come to an answer here? Excellent, excellent. I don't see the name. The answer is correct. Responded to PPI. Now, this is the very important keyword for you all to come to the answer. This patient has responded to this PPI of 40 milligram. So, he has had a response. This is not a failure. So, he has been on it for 5 years and he has responded to it. But I don't know why they did this pH assessment. But anyhow, they have done it. And they see still the pH less than 4 is about 10% of time. Okay, so that means though it has responded, it's not adequate yet. So what you can do is you can try increasing it. So the best thing would be if he is on a daily dose, you can increase it to BD dose. So then you can try it, as he has already responded, this might work. Fundoplication not indicated at this stage. That's why, because of the keyword I told, responded to PPI. If he hasn't responded, yes, you might consider fundoplication. Now, elevating the head end, yes, it is a management that is a non-pharmacological management. But here you have to select the best answer out of the 3. This itself would not be enough for this to tackle this problem. So the correct thing, or the best thing that you can do would be increasing the PPI, which is answer A. Okay. Okay. Now there's a question. Here 5-year duration is a red flag till we should increase. Now the thing is, here 5-year duration, more than 5 years is a red flag, but here he has responded. They don't tell anything about his symptoms being persisting. That's why I asked, I don't know why they did this pH assessment, because he has jolly well responded to this treatment. So you can't consider this as a red flag here, though it's the cutoff. Okay, then if there's an option to do nothing, no, if there's an option to do nothing, still you're going to increase the PPI. Why? Because this is a significant period of time, pH less than 4 for 10% of time. That's very significant. So you should increase this. Why? If not, why should you increase this? Can somebody mention? Why should we increase this even though if there was option to give option nothing? Yes, excellent, Dr. Salma. To prevent metaplasia and the development of Barrett's esophagus, because that's a complication. So you have the evidence that this acid suppression is not enough by this pH value. So you should increase this to prevent it from transfer into metaplasia. Having said that, in a patient with GORD, surveillance endoscopy or surveillance pH monitoring is not usually recommended. That's why I don't know why they did this. Okay, another question. If option was to do gastroscopy, No, if the option was to do gastroscopy, not here, because here this is a clear-cut case of PPI. Now, patient regurgitation responding to PPI itself is like a confirmation of GORD. So you don't need to do gastroscopy here because there's no red flag features as such. No weight loss, no any other atypical features. Okay, did I answer all the questions? Meaning of elevating the head end. Elevating the head end means like so that keeping a pillow or something for sleeping and all, so that the acid will not come up. It is like using the gravity to prevent the acid reflux. Can you please repeat pH with time period? Okay, I'll just go to that. pH with time period. This one. Okay. Okay, so I'll just tell it. So here this is what I told. So usually we consider pH value of less than 4 as a significant value, and not only the pH value, we need to consider the total period in which the pH was less than 4. Okay, so they have this normal value table. You don't need to memorize this. Don't worry about this. This is just to give you all an overview. So the percentage time in which pH was less than 4, for example, they have calculated in proximal and distal part of esophagus. So in the proximal esophagus, the total period of pH less than 4 being less than 0.9% is normal. So if it is more than 0.9%, that is abnormal. So what I told is like you have these values, just see all these values are less than 10 or else even less than 7. So you can just roughly remember it like that, less than 7 or so. So if it is more than 7, in our case, it's 10. So it's a very significantly high value. So it shows inadequate acid suppression. Okay, did you get it? Okay, what is the, okay, so duration age is more than 50. Sorry, yeah. The thing is, when you consider red flags, you can't go by only one feature. Now, for example, a person with an age limit of age of 50. For example, age. If let's take his age is 50, then and he has a pure GORD. He has a pure GORD, but no any other features, no weight loss or any other things, and his GORD symptoms responded to PPI. But his age is 60, let's say. So although age 60 is a red flag, now you when you look at his clinical picture, you see he has responded to the PPI and he's doing okay. And so you don't need to consider gastroscopy just by considering only the age. But think his age is 60 and he has a bit of vomiting or regurgitation as well associated with the GORD, and he's not feeling well, there's a bit of weight loss, then yes, you should consider gastroscopy. You should look at the overall clinical picture. Okay. Okay, now age 60, duration of symptom 5 years, yes, but it has been controlled with PPI. That's why I told controlled with the PPI is the keyword here. If it was not controlled, if they say suboptimal control, on and off the symptoms were still there, though they were treating with PPI, it was not responded, yes, then you have to consider gastroscopy. Okay, did I answer all the, what is the maximum dose of PPI? Yeah, maximum dose of PPI actually, you can, that depends on the different PPI. So you can go, I can't actually remember all the values of all the PPIs, but generally you can go even up to 30 milligrams per day. Yeah, even up to 30, sorry, not 30. Even up to now for pantoprazole, I think you can go up to 240 or so. So likewise, there are different cutoffs for each, but 40 milligram BD you can go. That's not a problem. I can't remember the exact values. Okay, why are we increasing the PPI if surgery, if SX are controlled? I can't understand that question. SX, I can't understand what. Okay, symptoms. Now, why are we increasing this if the here? Because if the symptoms are controlled. Now here, that's why this question is not complete. Now they have said it is responded to PPI, but they have done a pH assessment and that shows pH less than 4 for the 10% of time. So that is significant. To prevent it from transferring to a metaplasia, we have to increase the PPI dose here. If this pH assessment was not done and if he has responded really well, actually you don't need to increase also. Because of this pH only, you have to increase the PPI. Okay. Okay, I can't understand time expressed in percent. Time expressed in percent means now maximum. Now, for example, the pH of the esophagus can vary. 4, 5, likewise, it can vary. They are calculating for how long the pH was less than 4 out of the 24 hours. They are doing it for 24 hours. And out of the 24 hours, for how long the pH was less than 4. And they are converting it to a percentage. And that percentage is the one that was expressed in the table. For example, 0.9% means if it is less than 0.9%, that is normal. But if it is more than 0.9, that is abnormal. So what they are doing is they are calculating the total time period in which the pH was less than 4 out of the 24 hours and they are converting it to a percentage. Okay. You got it right? All right. So, okay, thanks. All right. So let's move on. Now we have been spending quite a lot of time here, but there have a lot of questions. All right. So let's move on to the next one. Aboriginal with recurrent otitis media with waxy ear and oozing cannot hear clearly from his right ear. What is the initial step in management? 1. Ear toilet. 2. Paracetamol 4 times per day. 3. IV penicillin. 4. Oral amoxicillin clavulanic acid. 5. Referral to ENT. Now this is an Aboriginal. The age is not here, but commonly this is a presentation of children. So think of it as a child. Recurrent otitis media with waxy and oozing. Cannot hear clearly from his right ear. What is the initial step in management? Now, this is the keyword. What should you do initially? Should you do, okay, so, okay, so most of you think we should go for an ear toilet. Some think we should do a referral and some are for antibiotics. Okay, so just let me, before we discuss this question, I'll take you to this. So this is how you should manage an acute otitis media in the emergency department. Now this lacks an important finding, but just let me walk you through this. So when a child presents with this, you are going to obviously do otoscopy to see whether there's acute otitis media. And you are going to check whether there are effusion, whether there's a perforation, all those things you are going to do with otoscopy. Okay. If an acute otitis media is evident and there's a fever, vomiting, lethargy-like features, systemic features, then you have to go with antibiotics and analgesia. Okay. But if there are no systemic illness features, then you are going to check whether he has these features. Age less than 6, age less than 2 years with bilateral acute otitis media, symptoms more than 48 hours, severe symptoms, evidence of perforation, high risk of complications like chronic suppurative otitis media or mastoiditis, especially in this indigenous and Torres Strait Islander category of people. So if the patient belongs to this category, then you are going to start antibiotic after, then you are going to start antibiotic after telling the patient. Okay. Then if he or she doesn't meet the criteria for antibiotics, then you can tell them that you don't need an antibiotic. Most of them will resolve by 60%. And you can give an antibiotic prescription if the pain is more than 2 days. But yes, analgesia you can give to both these categories. It's not here, but you can give to both these categories. Now, if you, with otoscopy finding, if you see otitis media with effusion, you should consider ENT referral if it is more than 6-week history of effusion, perforation, or hearing impairment. And here, or else you can manage like in the other one. And they have missed another important thing, that is ear toilet. So if you see, when you in your ear examination, if you see lot of purulous pus coming, then you can't see anything else. Even otoscopy will not be possible for that. Then you have to do an ear toilet as a first step to clear all those things so that you can have a good visualization. Now, when it comes to analgesics, you can consider any of these, usually paracetamol or ibuprofen. Now, antibiotics, there are different guidelines, which I'm not going to touch now, but I want to tell you about this. Now, this is a separate guideline for Aboriginal and Torres Strait Islander children, otitis media. I'm not going to read all of these, just to guide you, just to show you all. Now, here you have different sections for different. Now, management of persistent otitis media with effusion. Then management of acute otitis media without perforation. Management of recurrent otitis media. Then management of acute otitis media with perforation. Management of chronic suppurative otitis media. Then management of dry perforation. Likewise, you have, for example, for chronic suppurative otitis media. Now, what are the antibiotics? Okay, so here you have like a nice table. The recommendation of the antibiotics, topical antibiotic, what you should do, and the prophylaxis, whether it's necessary or not, and ENT referral, everything is here. Okay. So this is a nice one which gives you everything about different types of otitis media. Because it takes a lot of time, you can leisurely read it. I'll send the link when I'm sending you all the note. All right. So having said that, now let's go back to our case. We have an Aboriginal. And coming with recurrent otitis media. Waxy and oozing, cannot hear clearly from his right ear. So this is very important. He has oozing and waxy ear. Now they are asking what is the initial step in management. Now, ear toilet, yes, you should definitely do an ear toilet as an initial step here. Why? Because lot of pus and oozing and waxy is there in this ear. Paracetamol 4 times per day analgesic you can consider later if the pain is severe after the ear toilet. IV penicillin, not necessary at this point. If he is severely ill, sepsis like fever and all, only you are considering IV drugs. Oral antibiotics, yes, but not as a first step here. Referral to ENT, yes, you should definitely do that because this is a case of recurrent otitis media, but not as the initial step. So this keyword is very important. They have asked about the initial step. So the initial step would be doing an ear toilet. Okay. So that's the correct answer. I have attached the links of the 2 reference materials that I used. You can leisurely go through that. Okay, next one. Paroxysmal nocturnal hemoglobinuria. Okay, there's a question. What to do after ear toilet, referral or antibiotics? That depends on, now if you are a GP, yes, obviously you have to do the referral. If this is at a hospital setup, can start the antibiotic and then get the specialist opinion. If otoscopy was an option, yes, otoscopy, you can do the ear toilet. You have to definitely do the ear toilet to visualize through the otoscopy. Okay. Paroxysmal nocturnal hemoglobinuria, what is the most appropriate diagnostic test? A, flow cytometry, B, PET scan, 3, C, MRI. So what is the correct answer? This is a bit easy one. But we didn't do anything relevant to paroxysmal nocturnal hemoglobinuria. There was a question in June, so better to discuss this. What do you think? What should be the most appropriate diagnostic test? Okay, so most of you think it should be A, that is flow cytometry. Yes, so what is paroxysmal nocturnal hemoglobinuria? Now there's a clonal hematopoietic cell disease, okay, all of you know that. Then what are the important clinical manifestations? You have like a triad actually. You have a hemolytic anemia, pancytopenia, and thrombosis. So you have those triad of symptoms that will constitute in paroxysmal nocturnal hemoglobinuria. So the this hemolytic anemia is an intracorpuscular hemolytic anemia. There'll be thrombosis of large vessels, and there's a state of pancytopenia. Now, principal study that is used to diagnose would be a flow cytometry. And a bone marrow analysis can also be considered, but it's invasive. So flow cytometry of peripheral blood is good enough to diagnose. Then treatment, there are complement inhibitors. So those like this your eculizumab and all those sumabs, they can be used for treatment. So that's like a brief overview. So the question we did was very straightforward. What is the most appropriate diagnostics test? Not a PET scan, not MRI, not indicated. It's a flow cytometry. Answer A. Okay. So that's like a brief overview. No questions on that. All right. Moving on. TSH low, T4 low, T3 normal. What is the investigation to do? A. MRI, B. prolactin, C. thyroglobulin, D. ultrasound neck. What should you do? Should you go for an MRI, a prolactin, or thyroglobulin, no ultrasound neck? Okay, so all of you think we should go for an MRI. Why should you do an MRI? Can somebody mention the reason? To see what? Yes, to see any pituitary cause. Now here you can, when you analyze this report, here you can see TSH is low. TSH is low. T4 is also low. Now ideally when T4 is low, TSH should be high because there is a feedback system that will, the low T4 will stimulate the pituitary to increase TSH so that it can work on increasing T4. But here that has not happened. So this is a state of hypothyroidism, but the pituitary seems to be not responding to this low T4. So there should be a problem with the pituitary, which is causing this hypothyroidism. In other words, this is a central hypothyroidism issue. So you should look for the cause of this by visualizing the pituitary, usually an adenoma or some sort of a thing. So that's why we are doing an MRI to check whether there are any pituitary or central cause that is causing this low T4. Okay, so that's why you are going for an MRI. All of you had correctly mentioned MRI, which is actually correct. Then what about prolactin? Not necessary here because nothing to do with prolactin here in this thyroid case. Yes, it will, the prolactin level might change if there's a pituitary disease, but that will not confirm a hypothyroidism case. Thyroglobulin not necessary here. Why? It is usually done when you suspect a thyroiditis case. Ultrasound neck not necessary because you are considering a central cause here. Now, if the cause, if suppose TSH is very high, T4 but T4 low, then of course TSH is there, but the thyroid gland is not responding to the TSH. Then you can consider ultrasound neck or some sort of a investigation to check for the thyroid issue. Here it's not necessary. Central problem is there. Okay. Okay. So I hope, okay, there's a good question. T3 normal. Can somebody answer that question before I answer? T3 normal. That's a very good question. Here T3 is normal. Why is that? T4 active form. Okay, I'll tell the reason. The reason is it takes some time for T3 to reduce in hypothyroidism. In clinical hypothyroidism, the first thing that will reduce, that in lab test you will see, will be low T4. Later, when it becomes severe only, T3 becomes low. So normal T3 will not exclude hypothyroidism. That's why you have to definitely do a T4 level. It will take time. Okay, so that's the reason. Now here, this is a nice table. I just included it for your reference. I'm not going to explain because I think all of you know this. So this gives you a nice overview of how do you interpret the T3, T4 and TSH levels. Since all of you correctly answered this question, I don't think I need to explain this. I just included just in case if there was a confusion to explain this. This you can leisurely go through how you interpret different thyroid tests, T4, T3 and TSH. So a very good and nice overview. All right. Let's move to the next question. 8-year-old woman diagnosed by psychiatrist as early Alzheimer and started on donepezil. Living alone, comes with her son to meet you in regular visit. Woman refused the treatment. Family under the impression that no need for treatment and she will be fine. What will you say? Now, this is a very important question and a bit tricky question. So what you guys are going to tell? 1, ignore donepezil. 2, ask her to take it. 3, ask son to make sure mom takes it. 4, if she doesn't take the drug, she cannot live alone. 5, refer to an aged care facility. What are you going to do? Okay, so I can see there's a multitude of answers in the chat box, which I obviously expected because this is a bit tricky question. So you should be very careful when you are dealing with the ethics questions. Some questions are very straightforward and very easy, but some you need a lot of thinking. Obviously, these questions are not very complete. That being said, okay, so all the 5 answers I can see. Some, yes, all, no, not answer 3. Nobody, yeah, all the 5 answers are there in the chat box, which I obviously expected. So let's go through this question. You have an 8-year-old diagnosed by psychiatrist says, this is very important. Early Alzheimer's. So this is not a late Alzheimer. The difference being, if it is a late Alzheimer, their level of functioning and all those things are very low when compared to early Alzheimer. And the psychiatrist, it is also very important. Diagnosed by a psychiatrist. This is not a GP diagnosis. This is a diagnosed by psychiatrist and started her on donepezil. So what does this sentence mean? This sentence means this lady has been diagnosed as Alzheimer's, but it is early. So she has some level of functional capacity. And this diagnosis is not a doubt because it was diagnosed by a psychiatrist and then he started her on donepezil. Okay, so that's what meant by this sentence. So then living alone, she's living alone. That is very important. Now she is all by herself. Comes to meet you with her son to a regular visit. Okay, she's coming for the regular visit. That is also very important. She is not like defaulting anything. She's regularly coming to you for the regular visit with her son. So son is also taking care of her, bringing her to the regular visit. Woman refused the treatment. Now, this is another every word in this question is very important. Woman refused the treatment. Now, she refused the treatment. She has every right to do so because that implies her autonomy. Now, family under the impression that no need for treatment and she will be fine now. That's a common misconception among the family members in most of the cases. What will you say? Okay. Ignore donepezil. Now, that is not a correct answer. Why? Because of this first sentence. It was diagnosed by a psychiatrist and he has started this donepezil. So you can't, as a GP or someone, you can't stop it or ignore it because he has started it because he thinks it's important and it's necessary. Ask her to take it. Yes, that's a very good option because she has refused it. So you should tell her, no, this is, and you ask her to take it, you should counsel her and tell her this is very important and you should take it. So that's a good option. Ask son to make sure mom takes it. Yes, you can tell it. You can tell the son to make sure that mom takes it. But there's a problem with that because this lady is living alone. The son is not always around her to like check whether she took it or not. He might be going for his work or anything as such, but you should definitely tell, definitely a family counseling is necessary here because the family members think she doesn't need a treatment. So they should be counseled. That's a very important step. If she doesn't take the drug, she cannot live alone. You can't decide on that. You can't tell you can't live alone if you don't take the drug. You can't decide on her living arrangements. You can suggest, but that's their right to decide on their living arrangement. If it is life-threatening, if there's any life-threatening problem only, you can involve. Refer to aged care facility. This you can do if you consider there's a major threat. And if they are not listening to you, and if there's a risk for her life or any sort of a thing. Now, nothing sort of that is, they are here. Now, the psychiatrist has started, she has refused. We don't know why she refused. Maybe she has not been counseled enough, or maybe she didn't understand why it was started. So referring to aged care facility, not necessary at this stage. Now, out of answer 2 and 3, you can talk to her and ask her to take, or you can tell the son to make sure mom takes. But I think you can understand now the correct or the logical step would be to ask her to take it, because she is living alone and she has refused. She has the autonomy for her decisions. So you should counsel her first. If she decides she wants to take it, nobody is going to tell anything. You obviously have to tell the family also, but here the best step would be telling her to take it. Okay, so that would be the correct answer here. I agree, Dr. Sana, I agree with B. I agree with you. In option B, it should be nicely worded. Counseling her and telling her the importance and asking to take it. So that's what it is meant. Okay, so that's a very good question on ethics. Next one, a lady presented with chest pain and palpitations. She was seen in clinic 3 months ago with the same problems. All the investigations were normal at that time. What is the diagnosis? A, factitious disorder. B, hypochondriasis. C, seeking attention. D, avoiding responsibility. What do you think is the correct answer here? Okay. Some of you think it's factitious disorder. Some are for hypochondriasis. Some are for seeking attention. Okay, so I think this, did you do this psychiatric disorders in your theory class? The factitious and okay, you have done, right? Okay, so that's great. So I don't need to explain a lot, but what I want to tell you all was, I hope you must be aware of this. According to DSM-5, now hypochondriasis no more exists. Okay, so they have given a broad term now for all those things, and that is known as a somatic symptom disorder. And the other rest of the people who doesn't fit for this are given another term, illness anxiety disorder. Okay, now all of these belong to somatic symptom and related disorders. Now, without hypochondriasis, you have a new classification, somatic symptom and related disorders. And they include all of this: illness anxiety disorder, conversion disorder, factitious disorder, and the somatic symptom disorder. Now, the hypochondriasis is known as somatic symptom disorder. Okay, so I'm not going to explain in detail everything, but just the core. So, now here, somatic symptom disorder, which was your previous hypochondriasis, what happens there is, now these patients, they have a symptom and they are very distressed about these symptoms, and they have like disproportionate thoughts. They think there's something severely wrong with them, and it must be a cancer or some sort of a thing, and they want to get a good diagnosis, and however much they are counseled, they don't believe, they think something severe is there. So that's why this disproportionate and persistent thoughts, high level of anxiety, and excessive time and energy. So they usually, what we call is, they go on doctor shopping. They go to different doctors to check because they are worried that they might have something severe. Okay. Now, in illness anxiety disorder, Now, in the difference is in somatic symptom disorder, somatic symptoms are present. So they have some symptoms. They have some motor symptoms. But in illness anxiety disorder, they might not have these symptoms. But still, they have high level of anxiety about the health, and they also worry a lot about that. And so they are worried about illness, but most of them don't have somatic symptoms. Now, when you take this conversion disorder, I think all of you know. Now, this is usually neurological symptoms in the conversion disorder. So that is either motor or sensory symptom. It doesn't have any other cause. Like if somebody is very worried about an exam or something, he or she might develop a right side paralysis, some sort of a thing like that. Factitious disorder is like this is like falsification or of physical or psychological signs, or they are by themselves they are inducing an injury or a symptom to show that they have some problem. This is also in other terms you might have heard the Munchausen syndrome. You might have heard that. So they are presenting themselves as ill, impaired, or injured. They don't have any problem as such, but they are presenting like that. Okay, so that's like the basic overview. You can leisurely go through that. So here we have a lady with chest pain and palpitation. Now this, she has somatic symptoms, okay? She was seen in the clinic 3 months ago with the same symptom. So this shows that though she is like going to several doctors or coming to this clinic several times because she's worried that she might have something sinister. All investigations are normal. This shows that she doesn't have anything major problem clinically. Now, in reality, she doesn't have any severe problem, but it's her anxiety, her thought that she is having a severe problem. So the diagnosis here, obviously, now here they have the word hypochondriasis. So it is hypochondriasis. It's not a factitious disorder because she has this chest pain and palpitations, and this is not something that she has induced. So it's not a cut or anything, something she has induced. Seeking attention, yes, she's actually trying, she's not trying to seek attention here. That's not a disorder as such. This is, the factitious disorders are the ones which are done to seek attention. Avoiding responsibility, not a disorder. Okay, so here the correct one would be answer B. But now the term is not there. Okay. All right. Quickly move on to the next one. Case of a child 18 months old with recurrent upper respiratory tract and runny nose. What investigation to do for diagnosis? 1. Urea breath test. 2. Chloride test. 3. Electrolytes. 4. Spirometry. 5. Chest X-ray. What are you going to do for this case? This is a child of 18 months. Recurrent upper respiratory tract and runny nose. What investigation to do? What do you think? Is it a urea breath test or is it a chloride test or electrolytes? Okay, so I can see the diagnosis is also mentioned in the chat box. Okay, as I always ask, can somebody mention the most important term in this history for the diagnosis? Most important keyword, very good, excellent, recurrent. Now you all are very familiar with that. Recurrent is the most important thing. Recurrent upper respiratory tract and runny nose. Now, if this is a simple one episode of upper respiratory tract infection, you are not going to worry a lot. This is recurrent. This shows some sort of an immune suppression or some sort of a vulnerability to illness presence in this child. So when you hear that type of a scenario, I can see all of you have mentioned cystic fibrosis is like the diagnosis that should ring a bell in your head. Okay, so when it comes to cystic fibrosis, okay, so I'm not going to discuss in detail, but a bit, no, not here. A nice account is there on your JM. So you can go through this. The JM, you have a nice account of cystic fibrosis, the genetic profile, and the clinical features, especially failure to thrive, and these chronic problems and recurrent infections, and recurrent diarrhea, those sort of thing, and other infertility, pancreatic insufficiency, those things. Now, diagnosis, we usually do this sweat test for elevated chloride and ammonium levels. And treatment, again, multidisciplinary care, physiotherapy, and all those things, and treating different symptoms. I think all of you know that already. Okay, so I just gave a brief overview. So here, this is a cystic fibrosis case. You should do chloride test. It's actually a sweat chloride test. So that is the correct answer, answer 2. Now, urea breath test, that is not a correct answer. We usually do this for H. pylori detection. So it's not necessary here. Electrolytes, yes, you can do an electrolyte here to see whether there are any deficiencies, but it is not a diagnosis one here. Spirometry you do to diagnose asthma. Now, this is not a case of asthma. Chest X-ray, not necessary here. Because you don't see any other indication for chest X-ray as fever or those sort of a thing. Okay, so there's a question, runny nose allergy. Okay, that's a good consideration, but that's why I told this term is the most important thing. Recurrent upper respiratory tract infection also there with runny nose. So there has been an infection also. So not a simple allergy. So there has been recurrent infections going on. Okay, so that's why we are considering a cystic fibrosis. Okay, next one. Weakness of both limbs lasted for 10 minutes. Diabetes, hypertension, and risk factors for stroke in the stem. Patient on insulin and other drugs. No visual symptoms or any other findings on neurological examination. What is the diagnosis? A. Hypoglycemia. B. Vertebrobasilar insufficiency. C. Carotid artery stenosis. Again, this is a bit tricky question. Okay, now there had been some question. How to diagnose asthma in toddlers, like spirometry can't be done. Now, we discussed it in the last class. In toddlers, when they can't, you can't do spirometry, so you go by the clinical criteria. In the last class, I posted you a link. In that, you have like a detailed description of like the clinical features and all those things to diagnose. Okay, so please go through that. You don't need to do spirometry because they obviously can't perform spirometry. Okay, so what do you think here? Again, a nice and an interesting case, this one. These questions are a bit tricky. That obviously because of that. Okay, so here I can see nobody thinks it's answer A, but there's a bit of confusion. No, there are few who thinks it's answer A. Some are for B and C. Okay. So now first, before I discuss this question, no. Now here you have a patient coming with weakness of both limbs. Now the age is not there, but let's think it's an adult patient. Weakness of both limbs lasted for 10 minutes. Okay, so that means now it is not there. Lasted for 10 minutes, means now it's not there and it has resolved. Diabetes, hypertension, and risk factors for stroke were there. Patient is on insulin, that means diabetes and other drugs. Now, the patient is on insulin, which is also very important because hypoglycemia can be there if the patient is on insulin. No visual symptoms or any other findings on neurological examination. So now, in the neurological examination, nothing was there. Okay. So what is the diagnosis here? Now you have hypoglycemia, vertebrobasilar insufficiency, and carotid artery stenosis. Okay. Why I say this is not hypoglycemia. Can somebody mention why is that? Why isn't this hypoglycemia? No loss of confusion, just limbs, no prodromal symptom, not. Okay, doc, very good, excellent. Yes, you don't see those things, all the answers are correct. But the predominant thing is, if this was hypoglycemia, this is a major hypoglycemic because for weakness to present, but usually it is coming with a confusion or that sort of a thing. But maybe someone can argue confusion might have been there, but still, if it is hypoglycemia, it will not resolve on its own. You need to give sugar or you need to give some sugary thing for it to settle. But nothing of that sort has been done here. So this cannot be hypoglycemia because of that. Very good, very correct. So vertebrobacillar insufficiency. I say this is not vertebrobacillar insufficiency. Can somebody say why is that? Why isn't this vertebrobacillar insufficiency? Yes. Yes, very good. Excellent. Important predominant feature would be a vertigo. Now, vertigo is not there. And there is a usually excellent ataxia or cerebral. In vertebrobacillar insufficiency, you get predominant cerebellar symptoms. It's not a weakness of both limbs as such. You will get a lot of cerebellar symptoms, predominantly vertigo. And these visual symptoms, they usually have either diplopia or loss of vision. Now, they have clearly mentioned no visual symptoms. So, you can't tell this is vertebrobacillar insufficiency because of that, no visual symptoms. It is clearly mentioned. So, this cannot be a vertebrobacillar insufficiency. So, this is a carotid artery stenosis. It will correctly explain everything because this is the TIA actually, transient ischemic attack, and carotid artery stenosis is a very good cause for is like the commonest cause for TIS. Okay. Now, some might argue now this says no other findings on neurological examination, but if there's a carotid artery stenosis, there should be a bruit. So some might argue like that. So what about what is the response from the others for that question that I'm raising? Okay. The bruit is not there. They say the clinical examination, nothing was there. So what about the bruit? Should it be there? Not always. Bruit should not, yes, very good. Not always. There should be a very significant stenosis for bruit to present. Okay. Now here there's a confusion in the chat box about the limb, weakness of both limbs. Now they have not mentioned whether it's upper or lower, but this should be, when you take the symptoms, this should be both upper limb and a lower limb, one side. Because there can't be like a paraplegia in carotid artery stenosis as such. So this should be both limbs mean upper limb and lower limb. So they have not mentioned it, but that should be the correct way. Okay. Okay, all right. So no more questions. We'll move on quickly. We'll do this one before the break. 30, no, before this, I'll come back to this. We'll do this one. As GP doctor, you want to help Aboriginal people to prevent STDs in their communities. What is the best way to do that? 1, TV advertising about STDs. 2, school campaigns for students. 3, posters in public transportation. 4, individual teaching for young adults about STDs and its complications. 5, scheduled events for students about this topic. Okay, what are you going to do here? This is also a question which needs... Okay, now I missed a question in the previous one. What kind of weakness is seen in vertebrobacillar insufficiency? It's usually an ataxia that is seen. Bilateral lower limb ataxia will be there in vertebrobacillar insufficiency, not a unilateral weakness, because it's a cerebellar syndrome. Like you will see predominant cerebellar features. Okay, now go through this question carefully. Now this question is obviously incomplete. You can't come to a correct answer as such. So you should go for like a method of exclusion. So let's see, I can see multitude of answers. Now here, this question is a bit difficult one. So you need to like work out correctly. Now here you are a GP and you want to help Aboriginal people to prevent STDs in their communities. What is the best way to do that? Okay. Now all of these ways have flaws, but you have to go by the best way. Now let's start from below. Number 5, scheduled events for students about this topic. Now, what is the problem with answer 5? Can somebody mention? Scheduled events for students about this topic. What is the problem with that? Excellent. Very good. So, not everyone who gets STD are students, because STD can be there in all the age groups, in adults and students, school going, non-school going, everyone. So scheduled event for students will not cover the adults. Actually, it's the adults who usually engage in all those unprotected activities in the most of the time, rather than the students. So doing a class for a student will not address the adults. So this is not a very good option. Individual teaching for young adults about STDs and its complication. Now, this is not feasible for one thing. You can't go and teach everyone individually as a GP. You have enough work to do. The next thing would be, again, this also targets young adults and not like a wide age group. So not only the young adults that you should target for STD. Posters in public transportation, this is a very good way because it will address everyone. But what about the people who don't use the public transportation? Not everybody will use the public transportation. So it has a flaw there. School campaign for students, again, this is targeting the students. Now, if this tells GP doctor you want to help Aboriginal students to prevent STDs, yes, you can do a school campaign. But here, you should target all the age groups. TV advertising about STDs. Now, here, there's a problem. Those of who don't have a TV, some might argue, might not like get this advertisement and might not get this knowledge. And the time period, there's a problem. So that's why I told all these 5 answers are not 100% perfect. But when you take the other 4 answers, the other 4 answers target only a particular group. But TV advertising will not target a particular group, not a particular age group. It will cover a wide range of age group. So for that reason, answer 1 seems to be better than the other 4 answers. Only because of that. Though it also has flaws, but the other 4 targets only a few groups. TV advertising will cover a wide range of people. For that reason, answer 1 seems better than the other 4. Okay? So because of that. All right. Okay, so now let's break up to have your break for about, last time there was a request to increase the break to 10 minutes. So because of that, we'll have a break for 10 minutes and then we'll come back to continue with the rest of the questions. Okay. Okay, are you guys back from the break? Can we start? Okay. All right. So let's start with this question. We didn't do it before. So this is a bit lengthy one. A 33-year-old woman presents with history of right upper quadrant pain and yellow sclera. Examination reveals unwell patient with abdominal tenderness but no guarding. Test results normal. Test results are given. So total bilirubin is 30. WBC 15, alkaline phosphatase 280, ultrasound abdomen, multiple gallstone, no pericholecystic fluid, common bile duct is dilated and measures 1 centimeters. Which of the following is the most likely diagnosis? A. Acute pancreatitis, B. Acute cholecystitis, C. Cholelithiasis, D. Ascending cholangitis. So what do you think? Though it's a bit lengthy, the diagnosis is not that hard. Okay. Yes. It's not actually Beck's triad, it's Charcot's triad. Yes, very correct. So what is meant by Charcot's triad and what is the diagnosis here? In Charcot's triad, you have fever, right abdominal pain, and jaundice. Okay. Hmm. Yes. So now see here you have a 33-year-old woman coming with right upper quadrant pain and yellow sclera. Examination reveals unwell patient and abdominal tenderness. Okay. So now I saw a good query in the chat box, confused between C and D because there's no fever. Okay. So do you guys know about any guidelines for cholangitis, diagnosis and management? Any guidelines or like a Bible of cholangitis, there's a guideline. Do you know about that? The diagnosis and all? No. Okay. So you have this guideline, which is your actually Tokyo guideline. Now it is the recent update is there. I'll just show you. I'm not going to discuss because now we are lagging behind the time. But I'll just quickly show you. I'll send you the link. Now this is like the gold standard for cholangitis and cholecystitis. So they have updated recently in 2018. So it gives you a nice overview of like how to diagnose and how to manage. Because it takes a lot of time, I'm not going to explain. But just see the diagnostic criteria for acute cholangitis. I agree the Charcot's triad is there, but there's a criteria here. So you have A, B, and C. A is systemic inflammation, B cholestasis, C is imaging. Okay, so systemic inflammation means either fever or if you have a laboratory data of inflammation, even that is a systemic inflammatory finding. Cholestasis is shown by jaundice or lab data. Now the lab data would be increased serum ALP, gamma GT, AST, ALT. Now here the lab data for cholestasis, systemic inflammation would be your high WBC, increased CRP and other changes. Imaging, if you have biliary dilatation and evidence of etiology on imaging, like stricture, stone, etc. So when you have one item in A or one item from systemic inflammation and one from either B or C, you suspect the diagnosis of cholangitis. But if you have one from each of these categories, then that is a definitive diagnosis of cholangitis. Now, in our case, I agree there was no fever, but the WBC count of the patient was very high. So there you have laboratory data of inflammation. The patient had jaundice as well as lab data for cholestasis. And the patient had biliary dilatation in the imaging. So the patient has all three of the all three features, and he fits very well for the diagnosis of acute cholangitis. Now, having said that, now they have nicely given the values of different things. Now, WBC high mean, it should be more than 10. So like jaundice or the liver function, these are the cutoffs like you have. Then they have also given for the criteria of acute cholecystitis, and then initial treatment, how should you treat and how should you manage, everything is there in this guidelines. I'm not explaining because it will take a lot of time. Okay, so with all these things, that's why I told now Charcot's triad, yes, there was a concern without fever, how Charcot's triad. That's why this question is a bit tricky, but it has evidence of all three categories that I mentioned. So here see WBC is high, you have bilirubin, high bilirubin, and you have AST/ALT high, jaundice, and the imaging shows dilated bile duct. So ABC3 all three are met. So this is a good diagnosis of cholangitis. So this is an ascending cholangitis case. Okay, so be aware of the diagnostic criteria. This is not acute pancreatitis. This is not acute cholecystitis. And cholelithitis not because of this is not a simple cholelithitis case. It has very good evidence to show that this is a case of ascending cholangitis. Okay, all right. Okay, so that's a genuine concern, and it's very important that you know very well about cholangitis and cholecystitis. Okay, next one. Man in ER. If I had time, I would have explained the management as well, but it will take a lot of time. So let's move on. Respiratory symptoms, dizziness and confusion after using kerosene oil-based garden equipment in his garage. What's the cause? A, it's a very easy one. Carbon monoxide poisoning. B, pneumonia. What's the cause here? A very easy question. Yes, undoubtedly, all of you say this is a carbon monoxide poisoning. Very correct. Why? He's coming with respiratory symptoms, dizziness, and confusion, which are very common symptoms of carbon monoxide poisoning. I'll show you the symptom list. And there's evidence for the source after using kerosene oil-based garden equipment in his garage. So, yes, this is not a pneumonia. That's very clear. And this is a case of carbon monoxide poisoning. Now, I'll just show you a glimpse of the reference. So here you have, this is a very lengthy one, a lengthy article by American Journal of Respiratory and Critical Care Medicine on carbon monoxide poisoning. So you don't need to go through all of these, but they have like nicely explained. So it's the symptoms. So it's usually diagnosed by a clinical triad. Symptoms, history of exposure, and the elevated carbon monoxide levels. Okay, when you take the symptoms, so you will have, where are the symptoms? Okay, etiology, symptoms, you have clinical manifestation. Okay, so these are the clinical manifestations: headache, dizziness, fatigue, nausea, vomiting, altered mentation, chest pain, SOB, like mostly respiratory symptoms, and sort of a neurological symptoms like confusion, headache, dizziness, those things. Okay, and they have nicely explained how the symptoms of different systems are there. Very lengthy, and the management is 100% normobaric oxygen or hyperbaric oxygen. That's the management for carbon monoxide poisoning. Okay, so that's a brief word on carbon monoxide poisoning. Okay. Okay, there's a question. Chemical pneumonitis. Yes, this is a chemical pneumonitis because of carbon monoxide poison using kerosene. Yes, correct. Should we read first options or question? Now, these questions are incomplete, which I agree. But when you do your mock questions, try to read the question first without seeing the answers. We call it as cover method. So you cover the answers and you read the question and think of the first thing that comes to your mind. and check whether it's there in the answers. Most of the time it is the correct answer. But some questions, it's very difficult. You will not have any clue. Then you go through the answers and try to exclude answers by the answers which are not fitting. For example, in this question, even if you didn't know that, you very well know this can't be a pneumonia because there's no fever, there's no features of infection. So you are left out in carbon monoxide. Likewise, if you have no clue of an answer question, you can go by the exclusion method. You can exclude the answers that do not fit and you can come to the answer that fits well. For example, in this question that we discussed earlier, all 5 now we don't have a clue, but we excluded 4 because they are targeting only a specific population. Then we were left with number 1, and when we analyzed this, we felt as it is the most suitable way out of the 5. So by exclusion also you can come to an answer in the cases where you have no clue. If you are very sure, you can just straight away read the question and mark the answer. Okay, but most of the time these questions in the exams are not very easy, so you will have to read all the 5 answers to come to the correct answer. Okay, now let's go through this. Pregnant woman after 24-hour eruption of rash characteristic of measles, diagnosis established. Let's do this question with exclusion method to teach you all the exclusion method. Okay, pregnant woman after 24 hours of eruption of rash, characteristics of measles, diagnosis established with certainty. Which one is the most appropriate next step? 1, give MMR vaccine. 2, give immunoglobulin. 3, contact tracing. 4, check her antibody status. 5, no action required. So I'll teach this question using the exclusion method. So first, okay, what do you think? Okay, so there's again multitude of answers. Some are for answer 3, some are for answer 4. Okay, so here, what do you have here? Now let's try exclusion. You have a pregnant woman. For the doctor who asked about how to do the question, please check whether you understand the exclusion method by this. If not, let me know, I'll explain again. So after 24-hour eruption of a rash characteristic of measles. So this rash has appeared, which is of measles, and after 24 hours, she is coming to you. And diagnosis was established with certainty. So there's no doubt this is measles for 100% sure. Which one is the most appropriate next step? So you have a patient with established measles. What are you going to do next? Okay, now give MMR vaccine. Okay, now this diagnosis is already established, right? So why are you going to give a vaccine? Vaccines are usually given for prevention. Now you can't prevent this. So this one, because diagnosis is established. That is one. And another thing is this is a live attenuated vaccine. So you can't give it in the pregnancy. So out of those 2, because of those 2, you are excluding this answer. Give immunoglobulin. Again, immunoglobulin, if the patient had an exposure before the symptom arises, to prevent it, you can give the immunoglobulin. But now the symptoms have already arisen. She has developed the measles. This is not a case of exposure. Here she has developed the disease. So giving immunoglobulin, of no use. That is also out. Contact tracing, yes. Now this is a measles, which is like a transmittable disease. So she might have contacted some other people who are not immune. So contact tracing is a very good thing to do. Let's check the other answers because we are going by exclusion. Check her antibody status. Now, why are you going to check her antibody status? No use, because she has already developed the disease. Checking the antibody status, we are doing it if she was exposed to check whether she is immune or not. This is of no point. The disease is already there. So don't confuse this case. This is not a case of exposure to measles and coming to you. This is a case of diagnosed measles patient coming to you. No action required. Okay, so that also seems like okay. No action is required for her because you don't need to give immunoglobulin, you don't need to give vaccine or anything. So now you are left with 3 and 4. You have excluded 3 answers, 1, 2, and 4. Now you have excluded these. So now you check these 2 to come to the correct answer, like most suitable one. They are asking for most appropriate. Contact tracing, No action required. Both are correct. But what should you do? Now, no action required will not do any harm. You are not doing anything to harm, you are sending. But contact tracing will benefit. Why? Because you are tracing the other people who got the disease from her and you are going to treat them or you are going to address their issue. So that is more beneficial than answer 5. So because of that, you are selecting answer 3 over answer 5. That's how you use exclusion method to come to an answer. You try to exclude as much answers as possible, and then when you're left with 2, you are thinking logically to check which is the most correct answer. Okay, I hope you got the method and you got the answer as well. Okay, now regarding the pre-exposure prophylaxis, I have included this guideline. Now I'm not going to teach it because it is pre-exposure one, but just to for your interest, this is how you do, post-exposure prophylaxis for pregnant women and all those things, how you do the post-exposure prophylaxis. That is not relevant to this. Okay. Okay, do we terminate? No, you don't terminate. Okay. All right, next question. You don't terminate, doctor. All right. 3-year-old baby with history of fever, cough and coryza, runny nose, chest x-ray given, asking for management. 1 oral roxithromycin, 2 oral amoxicillin, 3 IV ampicillin, 4 IV penicillin, 5 IV ceftriaxone. What are you going to give here? Okay. Again, multitude of answers. So what is the diagnosis that you see in this chest x-ray? Yes, very correct. Pneumonia. Consolidation. Excellent. Consolidation. What is like the precise diagnosis? What pneumonia or what consolidation? Yes, this is a right side upper lobe pneumonia or right side upper lobe consolidation. So they're asking you the management of a. Now the symptoms are also fitting: fever, cough, coryza, and runny nose. And chest X-ray is given. Here you can see the consolidation. 3-year-old baby. So pediatric pneumonia management. I think that must have been bread and butter for all of you now. So just a brief overview. You have this overview or guideline, community acquired pneumonia management. You have everything in a nice overview, but this flow chart gives you a very nice overview. So first you check when you have an outpatient, when you check whether hospital admission is required. If the hospital admission is not required, if it's a very mild pneumonia, you're going to manage discharge or send the baby away with oral amoxicillin. If hospital admission is required, if it is admitted, then you are checking whether there are features of severe pneumonia. So what are the features of severe pneumonia? Okay, so these are the features of severe pneumonia. Let me take you to that here. Severe respiratory distress, marked tachycardia, altered mental state, or saturation less than 80%, or complicated pneumonia with an effusion and all those things. So if it is a severe pneumonia, those are there here as well, features of severe pneumonia, sorry. Okay, if these features of severe pneumonia are there, you are going to give IV antibiotics, okay? IV ceftriaxone or flucloxacillin or vancomycin. If severe pneumonia features are not there, you are going to manage with oral amoxicillin or oral benzyl penicillin. Sorry, not oral benzyl, oral amoxicillin. Then, if they can't take oral, if they are very ill only, you are considering IV benzyl penicillin. Then based on the clinical improvement, you are going to discharge with amoxicillin or not. Okay. So that's like a basic overview of pneumonia management. Okay. Chest left lower side shows abnormal on X-ray. Okay. Okay. We'll go back to the question. No, this is the gastric gas bubble. This is not abnormal. This is the gastric gas bubble. That's normal. So here, now having said that, we have a baby with pneumonia. So is this a severe pneumonia or not non-severe one? Can somebody comment? Is this severe or not severe? Not severe. Very good. I think not severe. Okay. So you don't need to give. So you are excluding. If it is not a severe one, you don't. They have not mentioned anything about the baby not tolerating oral feeds or anything. So you don't need IV. So IV is not necessary. We are excluding all the IV options because of that. So you are left out with two orals, oral roxithromycin and oral amoxicillin. Out of these two, you know amoxicillin is the better one for community acquired pneumonia. Okay, so you are left with answer 2. All right. Clear? Okay. So let's go to the next question now. This one. Check whether you can answer this. Obese pregnant mother, POA 36, bilateral pendulous breast, BMI 42, can't palpate her uterus, ultrasound and CTG both normal. Refer to tertiary care hospital. What further assessment to do for her now? Blood glucose, lactation, dietitian, endocrinology, and anesthesia review. What do you think? Okay, so here you have an obese pregnant mother. POA is 36. Now the bilateral pendulous breast, this means the breasts are very large in size. BMI 42, so she's very obese. Can't palpate her uterus because of this obesity. That's why they can't palpate the uterus also. But ultrasound and CTG both are normal. So there's nothing to worry about the baby. They have referred to the tertiary care hospital. Now what is the further assessment to do for her? Okay, now let's see. Now this is a case of obese pregnant mother referred to the tertiary care hospital because it's very difficult. If in case she has to go for a cesarean section also, it will be very difficult. And even the normal vaginal delivery will be very difficult for her. So let's go through what are the assessments we have. Blood glucose, lactation, dietitian, endocrinology, anesthesia. Lactation, not necessary at this point. Now we are excluding, right? We are doing that method. Lactation not necessary at this level because she has not delivered the baby yet. Dietitian, yes, but dietitian, yes, you need because her BMI is high. So we'll keep it. Endocrinology, if you think of diabetes or some other metabolic complications, yes, but now there's no like a very big indication of any endocrine issue here. So at the moment, no endocrine issues that have been mentioned. So that has a low probability, but yes, you might consider. So let's keep this also, you can't exclude. We'll keep both of these. Anesthesia review, yes, because why? If she has to go for a cesarean, most of the time she might have to go for a cesarean section. Then giving anesthesia will be very difficult. Okay, if she develops any complications, again her airway maintenance is going to be very difficult. Even the spinal anesthesia is going to be very difficult. Okay, so that is also necessary. Blood glucose, yes, you might consider. Why? Because she is obese. So now we were able to exclude only one. We are left with 4. Now, what assessment to do for her now? They are asking now what are you going to do? So now let's try whether we can come to one out of these four. Dietitian now, yes. Endocrinology now, yes. Now you endocrinology, you don't need to do now itself because you don't see any impending any full-blown endocrine problem at the moment, though she is obese. But dietitian, you might have to consider now. Anesthesia, yes, you need it because you don't know any emergencies can happen at any time. Blood glucose, yes. So now when you take blood glucose, her POA is 36 now. They have not mentioned anything about she being diagnosed with diabetes. So ideally, the OGTT or the blood glucose measurement is usually done at 24 to 28 weeks. Since they have not mentioned anything about that, we should assume that it has been done and it was normal. If not, they would have mentioned. So now it's not needed at this moment. Okay? Because now the POA is 36. Now, because of that, we can also think a dietitian's help is not necessary at this moment, because if she was a diabetic patient, we would have needed a dietitian for her meal and other things at the ward. But she is not a diagnosed diabetic patient. But later, she might need a dietitian's advice on her weight reduction, not at the moment. But anesthesia review is very crucial at the moment because if she had to go for an urgent cesarean section or any sort of a thing, this is going to be very, very difficult. So because of that, you have to select answer 5 as the correct, like the most correct answer out of all the 5. Okay. All right. Clear. Okay. Next one. Female patient, 54 years old, diagnosed as chronic heart failure for 3 years. Symptoms controlled on captopril and furosemide. Presented to OPD complaining of intermittent dry cough for 3 months. No SOB, no orthopnea, vitally stable, cardiac and chest exam unremarkable, no lower limb edema or any signs. Chest X-ray clear with no significant signs. What is the appropriate next step in her management? A. Increase furosemide. B. Add inhaled beta agonist. C. Do pulmonary function tests. D. Stop furosemide. E. Stop captopril. What are you going to do? Yes, all of you have said we should stop captopril. Very correct. Very good. So see, you have a 54-year-old patient with chronic heart failure and see symptoms are controlled on captopril furosemide, and she's coming with intermittent dry cough for 3 months. Now see, this is very important. Intermittent dry cough. No SOB, again very important. If this no orthopnea, no SOB, no orthopnea tells us this is not an acute heart failure exacerbation in a chronic heart failure patient. So no SOB and no orthopnea tells us this is not a heart failure exacerbation. Vitally also stable, that supports that. Cardiac and chest exam remarkable. Again, is telling us this is not acute heart failure exacerbation or acute asthma or any other acute respiratory condition. No lower limb edema or any signs. Chest X-ray clear with no significant signs. All of these are telling us there's no abnormal respiratory or cardiac problem in this patient at the moment. So what is the most appropriate next step? So let's go through the answers. Increase furosemide, not necessary. Why? She doesn't have any lower limb edema. She doesn't have any features of fluid overload in the chest X-ray. So why you don't need to increase furosemide? Add inhaled beta agonist, again not necessary. Why? She doesn't have any features of asthma, and this is not a wheezy sort of a thing. This is an intermittent dry cough. You don't need to add inhaled beta agonist. Do pulmonary function test? Why? Not necessary at all, because all her basic investigations and examinations are normal. So pulmonary function tests are not necessary. Stopping furosemide? Again not necessary. Okay? Okay, Dr. Sharia. Fast, please. So is the speed fast or you want me to speed up? I can't understand. Okay? Dr. Sharia, I can't understand what you have mentioned. You want me to slow down or you want me to speed up? Just let me know. Okay, all right. So, okay, so then Stop furosemide, again not necessary. Why? Because he is a chronic heart failure patient. Now he is well controlled on controlled on this furosemide. So you don't need to okay, speed up, ma'am. Okay, so you don't need to change it. Then stop captopril? Yes, that is a very good answer. Why? Because we know cough is a very well-known side effect of captopril. Okay, so you can stop the captopril and you can give uh, something like an ACE receptor blocker instead of captopril. So this dry cough is a side effect of captopril. So you can stop it to prevent this. All right. So this should be the correct answer here. C. Okay. Yes. So questions. So change to ARB. Yes, you can change to ARB. What is the answer of previous question? Anesthesia review. Okay. So you can stop captopril and convert it to an angiotensin receptor blocker or ARB. Okay. Next question. 85 years male with ear pain. Heavy smoker with lymph node enlargement in neck. Very easy question. Biopsy of node reveals malignant cell. Ear exam is normal. Asking what you just look enough for diagnosis. Easy question. Yes, very correct. So this you have, all of you have said answer B, which is very correct actually. 85-year-old male, he's coming with ear pain, heavy smoker, lymph node enlargement in the neck. The biopsy tells us this is a malignant cell. So ear exam is normal. So this ear pain, how come this? So I think all of you know that ear exam is normal, but he has a ear pain. So this is a referred pain actually. Asking what you just look is enough for diagnosis. So this is a case of head and neck carcinoma, like all of you have correctly said. So what you just look to diagnose, posterior nasal exam, yes, you can do. Abdominal ultrasound, not necessary. Tongue, yes, definitely you should do. Salivary gland, yes, but you can't actually look in deep sense in salivary gland. You can palpate and see. So out of these three, like looking it is just enough for diagnosis. When you see this word, you know, you should first look at the tongue to exclude a oral carcinoma. Okay, so tongue will be the correct answer. All of you had correctly mentioned it. Now, okay, so there's a question. Kindly explain. I didn't get it. Okay, I'll explain it again. A is partially true because tumor there can cause tube blockage and pain in the ear. Okay. Now, this is somebody wanted me to explain this again. So this is a 85-year-old man coming with ear pain. He's a smoker. So that is a risk factor. And there's a lymph node enlargement in the neck. So they have done the biopsy of the lymph node and it shows malignancy. So that tells us this is a case of head and neck cancer or head and neck carcinoma. He's coming with the ear pain, but the ear examination is normal. So that tells you this is a referred pain from somewhere else, usually from the oral cavity. Now, tongue is a very good place from which there will be referred pain to ear. Teeth, there will be referred pain to ear. Okay, now they are asking, what you just look is enough for diagnosis. So now when you look, you will get the diagnosis. Something like that they're asking. So posterior nasal exam, you can't just look and get the diagnosis. You have to use additional equipments for that to get a clear view. But tongue, you can just look and see whether there's any lesion or whether there's any ulceration, which will tell you this is a tongue cancer. Salivary gland, again, you can't just look and tell. You have to palpate and you have to need additional investigations to see whether it's a salivary gland problem. Okay, so because of that only we are coming to the answer to tongue. The stem is incomplete, I agree, but because of this, you just look word only, we are going with tongue. Okay, now did you get it? Okay, you have got it. Thank you. All right. Let's quickly go to the next one. Now the very easy one. Scenario of a heavy smoking and alcohol consumption for 1 bottle every day with confusion and agitation and with labs of dearranged liver enzyme. What is the diagnosis? A1 alcoholic liver disease, 2 brain tumor, 3 stroke, 4 psychiatric problem, 5 cannot remember. I have included that as well, so you just cut it off. Out of those 4, what do you think is the correct answer? It's a very easy one, right? Okay, so all of, I think, wait, just let me check the chat box. Yes, all of you have mentioned answer 1, so that doesn't need any additional explanation. There's heavy smoking and alcohol consumption, confusion and agitation with dearranged liver enzyme. So this is a case of possible hepatic encephalopathy. So when you go through the diagnosis, alcoholic liver disease, correct. Brain tumor, not so correct because, not so correct because why? There are features to suggest this is something to do with alcohol. Stroke, no, you don't have symptoms or signs of stroke here. Psychiatric problem, you can't tell something as a psychiatric problem unless you rule out the organic causes. So out of these 4, the correct answer will be answer 1, which is alcoholic liver disease. All of you had correctly mentioned it. Very correct. Alcoholic liver disease to hepatic encephalopathy. Yes, Dr. Umeruman, correct. Next one. Man with urinary retention, mass 2 fingers above pubic symphysis. DRE showed enlarged prostate with smooth median sulcus palpable. Catheter was inserted. What is the most appropriate next step? I think this question must be very familiar to all of you. Urinary retention, mass 2 fingers above the pubic symphysis. This question is also from last month, June, but this question should be very familiar to you. You must have seen it somewhere else. DRE showed enlarged prostate. 1 urine cytology, 2 BPSA, C TRUS or the biopsy, D CT, E serum creatinine. Okay, what do you think is the correct answer here? Okay, some of you might have seen this in the handbook, similar question in the handbook. All right, so there seems to be a bit of confusion here. So let's try a man coming with urinary retention and there's an obvious prostate enlargement with smooth median sulcus palpable. This tells us this is not a prostate cancer because in the prostate cancer, you will not have smooth median sulcus. You will have obliterated sulcus and the prostate will not be very smooth. It will be very rough like that. So this is a case of prostatomegaly, most possibly benign prostatic hyperplasia because of this smooth median sulcus. So you have a patient with possible benign prostate hyperplasia, now coming with urinary retention, and they have managed the urinary retention with a catheter. Okay, so they are asking, what are you going to do next? So the next investigation that you are going to do should be of any purpose, should serve any purpose. Now let's go urine cytology. Some of you might think we are going to do urine cytology to check whether there are any pus cells or whether there are any any infection or some sort of a thing. PSA, yes, you can do, but PSA will anyway be high because this is a case of prostate hyperplasia. Biopsy, not necessary at the moment. Why? Because they don't have any features suggestive of a malignancy here. CT, not necessary because no features of malignancy are there. Serum creatinine will be very helpful to check the renal function because there had been an obstruction going on for a long time, most of the time, because they have not mentioned. Okay, so I'm telling this obstruction must have been going for a long time, most likely. Why am I telling that? Why isn't this an acute one? This is most likely to be a chronic retention. Why isn't this an acute one? Can somebody mention why am I telling this is a chronic? Yes, one is very good. Excellent, Dr. Cho. Pain. They have not mentioned anything about a pain. So this is not, if it is a very painful thing, yes, you would think of an acute retention, but nothing about pain is mentioned. And the second thing is prostate enlargement. They usually present with chronic retention rather than acute. So this has been going on for a long time. So doing serum creatinine is very important to check the renal functions because this might have affected his renal functions. So out of these three, now PSA, urine cytology, and serum creatinine, PSA is not going to serve you any purpose. PSA will be anyway high. It will be also high because of this catheterization. So no use of doing a PSA. Urine cytology not necessary at this point because they have not mentioned anything about fever or any other thing, hematuria, any sort of a thing. So not necessary at this point. But because this retention had been there for a long time, you should definitely check his kidneys. So the best next step, most appropriate next step would be checking his kidneys. That would be by doing a serum creatinine. Okay, so answer should be answer C. So this is a handbook question, obviously. So you can go through the handbook and see it. Actually, they have taken this question directly from the handbook. Urine microscopy or culture in option. Microscopy or culture. Still, we would go with serum creatinine. But if there was a question, if this patient had fever, patient coming with high-grade fever and chills, some sort of a thing, and dysuria and low abdominal pain, then you can consider urine culture because nothing of that sort is there. This is a clear case of chronic retention. So in chronic retention, your priority should be relieving the retention and checking for the serum creatinine. Ma'am, if urine microscopy and culture is given as option, do we go for that answer as next step? Not in this case because they haven't shown any features for any infection. No fever, no low abdominal pain. So no features of infections are there. An infection is there. So you don't need to do any culture or anything for this. But if there was a fever and all those of symptoms to suggest any infection going on, yes, then you have to do urine culture, UFR, full blood count, all those things. Here, this is a case of chronic retention, so your priority should be checking the kidneys. Okay, so correct answer is creatinine. Okay. So this is actually straight away from your handbook, directly, like they have taken this. Next one. Patient was at a party, developed chest pain, ECG showed ST elevation, troponins were elevated. What else should be done? A, urine drug screen, B, blood glucose. Now, until you answer this question, a word about handbook, it's wise to do the questions in the handbook because some questions in the exam you can see are like they have taken from the handbook, like the patterns. So it will be wise if you just have an overview of the handbook questions also. Okay, so this again an easy one. All of you have correctly mentioned answer A. Yes, very correct. He had been at a party. He has developed his chest pain. ECG showed ST elevation and troponins were elevated. So now in one of our previous recalls that I did with you all, we discussed that drugs can cause various cardiac problems. And they can cause chest pain, ST elevation, MI, and all those things. So urine drug screen, yes, that's a very good thing to do because he was at a party and he developed this problem. Blood screen, blood glucose, not necessary because hyperglycemia will not induce an MI as such. So the correct answer is answer A. Very good. Yes, okay. Next one. We'll do this as the last question for today because we are almost close to finish. Elderly man in home due to dementia assaulted a nursing officer, blames anyone who walks close by his room. When you go to home, he is peacefully hanging around. What to do? 1. Ignore as he is now peaceful. 2. Move him to the dementia-specific section of the elderly home. 3. Start treatment based on past history. 4. Take history about his assaults and progression. Okay, 5. Cannot remember. We'll forget this. Okay, what do you think? Again, an easy question. Okay, so there's a confusion between answer 2 and answer 4. Okay, let's see now. This elderly man, he is there because of dementia and he has assaulted a nursing officer. And he blames everyone who walks around. But when you go, he is peacefully waiting without doing anything. So what are you going to do? Ignore as he is now peaceful. That is not a correct answer. Why? Because he has had a history of assault. So ignoring this problem is not a good option. Move him to the dementia specific section of the elderly home. Yes, you can consider this. Next, go through the other answers. Start treatment based on past history. No, you are not going to start anything based on this past history. Now, who knows? Sometimes he had done this assaulting the nursing officer because of a reason. We don't know why he did that. And he blames everyone who walks. And so now he is peacefully hanging around. So these 2 episodes had been there in the past, but now he is peaceful and he is not a threat to anyone anymore. So maybe now something has changed. So you don't need to rush and do anything at this point. Take history about his assault and progression. Okay. So this is also there. So we are left between answer 2 and answer 4. Yeah. Starting treatment based on past history is wrong, but if you talk to him and if you sort it out, you can start. So out of answer 2 and 4, what are you going to do? Now you are left with answer 2 and 4. Answer 4, take history about his assault and progression. Now that is the first step that you are going to do, right? Now you have this patient, you are not going to now somebody is coming and telling now that he assaulted the nursing officer and he is blaming everyone. You are not going to straight away put him to somewhere. You are going to talk to him or you are going to check what has happened, take a history examination. That's like the basics in medicine, history examination, investigation. Now that he's peacefully hanging around, this is a good time for you to talk to him and ask why he behaved like that and what's the issue. And then if you feel that he will go back to that previous state or he will need some sort of a specific area dedicated for dementic people, then you can move him to the dementia section. But now, first, before moving on, you might have to move him. But before that, you have to do taking the history about his assault and then progress. So that would be the most logical step at this point. After that, you can consider the rest of the steps. Okay, so that's how you select between those 2 answers. And the correct would be answer 4. Very correct. Most of you have answered that. All right. So I think we have almost past 10:30. All right. So thank you very much for joining today. And thank you very much for your active participation today as well. Hope it was a good session and thank you for making it very interesting by your feedbacks and your comments. All right. So let's meet on another day with some new set of questions. Thank you again for joining today and have a good night.